Thank you. Good morning. Figure out how to use this. The core objective of this project is to use telehealth to deliver optimal team-based kidney care to our patient population throughout the North. This project was initiated largely due to our patients and their families in the remote communities and their stories of hardship associated with traveling to clinic appointments. We have actually had patients who have refused follow-up care with our kidney care clinics in Prince George because of this reason. This additional slide helps to show a couple of our farthest communities and the distances that our patients have to travel to come to Prince George. For example, Fort Nelson to Prince George is about 800 kilometers each way, so it's about a 10-hour drive. And Prince Rupert to Prince George is about a 700-kilometer drive, which takes about 9 hours. Anybody coming from Haida Gwaii also has the addition of a ferry ride, which, depending on the schedule, we're told can add about 4 to 5 days to their trip. There's many costs associated with this. Some of it is airfare, which can be about $600 to $800. Hotel costs, fuel costs, and in addition to all the time and costs of travel, our patients and families also have to worry about very hazardous road conditions at least 4 to 5 months of the year. This slide illustrates the historical problem of poor outcomes for patients with chronic kidney disease in northern BC. The geographical expanse of northern BC, with many small, rural, and diverse communities, limits access to optimal care for individuals with chronic diseases. As a result, northern BC has higher prevalence of chronic diseases like obesity, diabetes, cardiovascular, and chronic kidney disease. Despite the efforts of the Health Authority to enhance services locally, access to longitudinal and sustainable specialist team-based care when needed in their community is limited, often variable, and too late. This leads to higher chronic disease burden, medical emergencies, and prolonged hospitalization. So the problems. To summarize some of these problems we've mentioned in the previous slides, there is an increased prevalence and poor outcomes of patients with chronic diseases, specifically kidney disease, throughout northern BC. There is not equitable access to specialized team-based care for all of our patients. It is harder for patients who live in remote areas to access the team, which is largely based in Prince George. It's quite costly for travel to clinic visits. We've heard from many patients and families that they feel it's a long way to go for just a visit that takes about 2 hours. Currently, we have patients in remote areas of northern BC who do not come to clinics in Prince George for follow-up appointments as much as they should due to the cost and distance of travel. They basically say they will not travel. At this point, we are still mostly relying on our Prince George-based team clinics, which we know is not sustainable or suitable for our patients in remote communities. This project is being done in collaboration with Northern Health, Specialist Services Committee, and Provincial Health Services. It's a pilot project that we've just started this September. It's going to be running for 3 years. We've just hired a project manager in September, and we have a nurse who's in the position of the clinical practice consultant in Terrace. This position has the primary function of the CKD nurse, but also has the expanded role of providing ongoing education and support to the primary care physicians and teams, as well as being the point person for any questions in the local communities. We're starting with our project with Terrace in the Northwest region, as there was already a nurse in that area, and we were already doing telehealth in its basic concept to that patient population. In year 2 to 3 of the project, we'll be establishing the same format in our Northeast region in Fort St. John. Throughout this project, there will be opportunities to collaborate with all the primary care physicians and integrated teams throughout Northern Health, as well as with First Nations Health Authority. Some of the highlights of our project will be to provide care to our patients in remote communities with the use of telehealth equipment. Telemedicine is a robust means to deliver outreach specialist care for individuals in remote communities. It can improve patient access to specialist care, and contribute to better disease outcomes. We already have established a centralized referral system for nephrology consultation, but we'd like to expand that to include specifically telehealth consults, not just the face-to-face. We would like to establish continual follow-up specialty team-based care for all Northern Health patients that mimic as close as possible to the face-to-face team clinics that are currently done in Prince George. Right now, when patients come to Prince George for our clinic visits, they see each team member individually, so they see the nurse, the pharmacist, the social worker, the dietitian, and the nephrologist. We feel that the community-based clinical practice consultant is integral to the success of this project, as they are in continuous contact with the patients and families from that area, as well as being the person working closely with the primary care physicians and integrated services. What we are hoping to achieve with this project is to allow patients throughout Northern Health better access to care and more choices that will hopefully help prevent the lapses currently noted in their follow-up. Currently, we have video conferencing equipment set up in one room in Terrace and one room on the Prince George side. So the patient sees the nurse in Terrace, and then the patient will, on the other end in Prince George, the whole team sits together in one room and sees the patient together. We are working with IT and telehealth to set up a system of smaller video conferencing monitors that would work from individual desks so the patient can actually rotate through just like they would a face-to-face visit. We know that communication and education with all the local primary care providers and integrated teams will be essential in making this a sustainable success. With that, there will be frequent and ongoing meetings with the whole kidney care team and the local communities, as well as ongoing support from the local clinical practice consultant. Ultimately, our main goal is to make a difference in our patients' lives by offering them this alternative and improving their outcomes. Some of the questions we're hoping to answer throughout this project are, what is the best way to use telehealth? We've already started telehealth in its basic capacity, but we want to find out what is the best way to use this system for our ongoing follow-up care to our patients in remote communities. Can telehealth actually become part of our everyday routine with all of our kidney care clinics, including transplant, PD, and home-based therapies? Right now, there's a lot of planning, coordinating, and time involved in setting up these telehealth clinics. Can it become easier and more sustainable? What things do we need to do differently? Is it just getting more telehealth equipment that is needed, or do we actually need to think about changing our clinic model? And lastly, but most importantly, will this make a difference to our patients, both in clinical outcomes and quality of life? Thank you.
Thank you, Sherry. And we have a question here from the audience.
Maureen from BC Transplant. When a patient is first looked at, are they given the choice to be seen in telehealth or go to Prince George? And do they have to consent? And what literature do you give them regarding the telehealth clinic?
Yeah, we're just in the developing stages of all the forms and consent forms and everything that'll be needed. Most definitely they will have a choice. We realize it's not for everybody, but we just want to be able to offer them that choice so that we don't lose people in the cracks.
Perhaps we'll hear later with our telehealth lecture, the plenary session. But it leads one to think, how small can you go in terms of the scope of it? Like, so you're setting up regional telehealth centers with a nurse, but could one just, for example, FaceTime a patient in their home?
And that is some of the things that we're working with. I'm not a techie person, so I'm having a hard time visualizing all this. Our telehealth people tell us that everything's possible. So hopefully within the 3 years of the project, we'll be able to look at stuff like that.
Great. I had another question too. Do you have any sense of the numbers of patients who had declined health services because of geographic reasons? And presumably that's a number that you'll be capturing, how many more of these individuals you will be seeing and treating?
And that'll be one of our indicators to kind of look at throughout the 3 years of the project. Rough estimate, what we're being told, and this isn't a factual, it's just what we're being told, there's probably about 50 to 100 in the Northwest region and probably another 30 to 50 in the Northeast region.
quite considerable numbers
Yeah.
when you're talking about 300,000. Yeah. Interesting.
Mm-hmm.
Great. Any other questions from the audience? We can bring a microphone to you if you don't want to stand up at the podium. Don't be shy. No? Okay, great. Thanks then.
Thank you.